left MCA territory stroke in 2023, and 2 months ago yes, we was focused only on this supraclinoid ICA. We took a distal access catheter and placed the coronary stent. And now it's a problem number 1. We need to pass this segment with the wire, and we need to take our narrow speed balloon 1.5 by 8, and there is a critical stenosis in M1 segment. My colleagues measured M1 distally, it's a 2 millimeter, and at the level of stenosis is less than 1 millimeter. Now we passed with the wire stent, but it looks like stent went a little bit from upper part.
Question, this was a drug-eluted coronary stent?
Yes, it's a drug-eluted coronary stent, Science Alpine. I think it was a 3 millimeter. Just a second.
Can you give some information about the clinical presentation of this patient? Why you indicated for stenting?
This patient after ischemic stroke in left MCA territory. It was a 1 stroke and TIAs, that's why it's an indication for the treatment.
So the patient started medical treatment and failed?
Usually with the critical stenosis, we don't wait for the second stroke as it's usual practice in Europe and other countries. It's not only 1 stroke in our experience.
So do you have any perfusion study before deciding the treatment, such type stenosis?
There is no perfusion imaging. It was tight stenosis in ICA, and we forgot about the stenosis in MCA. That's why today we are here. Yes.
And you stand after the first stroke, even if the patient was not under vestibular treatment before, or you just stand when you got the stroke under vestibular treatment?
No, it was a stroke on before the best medical treatment. We administered dual antiplatelet just before the first treatment in Astana.
So I think it's always a discussion about the samples, what we learned more or less from samples. And of course, when there was no antiplatelets, we should perhaps not go for stenting. And on the other hand, when I talk to our neurologists, so let's put him on platelets and atorvastatin, and after the next stroke he gets double antiplatelets, and after the next. So how many strokes should we wait for before we do something? This is the other extreme end. But here the question might be, right, is this MCA stenosis so critical, so high grade?
Yes, but I think this is a niche area for the frailties, and you have the fear if we put a stent that we can...
Stent аш пересаш? Бах, 4-20. Stent.
So I think there's a huge difference in risk between the carotid stenosis intramural and the MCA stenosis. The carotid stenosis instead already is more prone for rupture, and this one is more prone for permanent infarction. So what do you do now? The wire?
Yes, now we passed like J through the coronary stent. And now narrow speed balloon 1.5 by 8 is in place at the level of stenosis. And just one technical point, this is a plastic from the narrow speed. It's located here. And it was very short segment of the catheter remaining outside of the Sofia plus 131 centimeter. That's why we took it out, this one. I think it's a little bit notice for the Akandis company. Yes, for some reason this.
So it's proximal close to the hub.
Yes, it's proximal close to the hub.
Resistance, and you remove it to have more working here. Yeah?
Yes.
Right.
Dr. Mynzhylky, what was your degree of stenosis? Based on the measurement, the stenotic region is 0.8 and the interstitial is 2.1. That would be less than 70%.
I think it's more than 70%. Okay, now we are inflating till 6 atmospheres. It's a small balloon and it's not all the time visible. Huh? It's not visible. Just a second. Еще раз. And actually, the size of the balloon between two markers, so it's 8 millimeter. But this balloon is not 8 millimeter, it's usually 15 millimeter. Сейчас, секунду. Окей, еще раз. Надо будет надуть и подержать. I'm asking Davlet is assisting me with Abzal to inflate the balloon and wait. It's experience from Chinese colleagues. They're inflating the balloon and keeping balloon in place for more than 1 minute. But we usually inflate and deflate, and now let's do the same. Balloon is 1.5. Yes, there is also A1 segment stenosis, but it should be ACOM, and that's why we just stand the M1 segment. Kind.
So you have it inflated now. I cannot see it.
Yes, it's inflated. David, now you can see, I hope. Назад. Yes, now we deflated. Yes, and with narrow speed, if you overinflate till 1.5 till 14, it will be 217 millimeter. It's a very important point of this balloon. Okay, I hope it's okay. We don't need more. If we do more, we can do complication. I think 420 corridor hill is on the table. Today it's a 420, but usually we use 520. 520 is on the way, but it's not yet arrived. That's why we will use 420. Paul, you have a lot of experience with this
So
system.
I know there's also a 3 by 20 and there's a 2.5 by 20 or 15. Why do you oversize the stand so much? Because when you make a PPA with 1.5 and you want to place a 5 millimeter cradle, what's the rationale behind it?
The rationale is a radial force, and we used 3 millimeter. We used 3 millimeter credo for MCA, and the artery became stenotic, and then we placed 420 for M2 segment, and stenosis was resolved. That's why we shifted from 3 millimeter for 5 millimeter, and we're using 5 millimeter also for P1 segment, and it works very well, and I think it's a good indication to use bigger size of the stent. The stent has.
Do we have more intimate hyperplasia when you're using the reduced stents?
No. In our experience, with the Credo, there is no intimal hyperplasia, but with these atherosclerotic changes, usually it's a restenosis. Usually at the level of stenosis, there is a restenosis, but not on all the lengths of the stent. It happened. Just a second. Yes.
You don't oversize. You don't. I personally slightly oversize. I think it's you have a laser cut stent which has a lot of gradient force from the beginning, in opposite to graded stents, whatever. So it might be reasonable to oversize, but normally it's always a little bit oversized. And from my impression, it's enough. But how much gradient force would you really need? Who knows the answer? I don't know.
Okay, we now position the stent, and this stent has 3 markers. The marker number 1, distal one, there is 3 markers, and then medium marker is a little bit longer. It's a medium part of the stent, and the proximal markers, also 3 markers. And there is a pusher wire distally, and now we are ready to place the stent.
Hanging margin. The oversight, the placing the stent in this anatomy, and there is a sudden change in the diameter, the caliber of the vessel, and the laser cut stents don't oppose well at the ICA bypass when we are landing from the MCA to the, because we have very short margin of landing here. So there are chances the proximal part of the stent may not oppose well.
It's a 4 millimeter, it should be okay. Tariq?
Yeah, so that's what I was coming to about the oversizing from landing to the ICA.
Yes, it's one more reason to have a little bit bigger stent. Huh? Okay, I think we can. It's good position, and we can continue. And radial force of all these stents like Credo and the Pegasus, I think, is not so much. And it's all the time this problem with the proximal markers. Huh? It's not recommended re-entry to the stent, but time to time we are doing, but mostly in the basilar system, I think there is no need to go inside the stent in this anatomy. In basilar it's usually okay. Yes. Okay, let's see. Okay. Just a second. Again, it's local anesthesia. Yes, we did the PTA and placed the stent, but the stenosis percentage is nearly, it's close to the initial. Even it's a 4 millimeter stent. Huh? Okay, we will try to go inside the stent. Okay. I think it's not detached. Yes, it's also the same disease like in Leo baby. If your marker is not moving from the stent, sometimes it's not detached.
Would be my next question. What are the strategies now when you get hooked with this so-called crown sleeve?
I think we should.
Same like Baby Leo or Acero or other also with Elvis Canadian.
Yes, usually we move the wire, and we are doing the same movement like with the Leo. We are rotating the delivery wire half 10 times, and usually it's detaching. I think it will not go, and at this point we can do Control Enter and Control CT, and if CT is clear, then we can finish. Ağa kımıldamağınız. Ağa kımıldamağınız. Yes, okay. Okay, just a second. I think we need to measure the stenosis before. Yes, it was 0.8 millimeter before, and now just a second. 1.3. I think half millimeter is more than okay. And if you have any other presentations, we can finish the stream, or we can do expert CT and finish. Nader?
Okay, Nader left already. Thank you very much. Congratulations for this illustrative case, and bye-bye. See you tomorrow here. I heard that you will come.
Yes, see you tomorrow.
So we will close this session now, and thanks everybody for coming.
Thank you, see you tomorrow.
Bye-bye.
Bye-bye. Алдындағы істен қарайсыңшы? Дұрыс тұр ма? Окей, қарайсың. Нормально. Минус 5. Минус. Да, нормально. Окей. Эксперт сети. YouTube продолжается, да? Не, продолжай. Жень, Наталья. Продолжай. Ага. Ақсақал қорықпай жата беріңіз, стендіңіз қойып қойдық. Бәрі жақсы. Қазір бітіреміз. Так, звук можно пока на время. Dear colleagues, CT is ready, and you can see the MCA territory is clear. Okay, let's see the sagittal view, and I think we need to check the previous stent, and I hope it's okay. A second. As we little bit moved the proximal part of the stent, and let's check the last angio. This was the last angio. Yes, on the angio, the stent is okay. Okay, now we can do one more angio, and then we can finish. Okay, let's do one more angio. If angio will be clear, then we can finish. Okay, dear colleagues, we measured the ICA and I think we need to place a carotid stent before the finish. It will be one more stent, just a second. Наша солнце. Бах. Аласыр. Абзал. Okay. Yeah. We are planning to place exact stent from EBIT 9740. Оно гайд нейромаксу, да? Я салқылыр. Окей. Now we are ready. Just a second. I will take out Sophia. Yes, it's very helpful to use distal access catheter in such a procedure. We'll change the connector. Аналичный физростер вытханит. Не смерзишь. Барыкин. Угол барыкин. Okay, we took a 14-wire Xeon Blue and now exact stent is arriving. Okay. Now the stent is in place. It's a 9x740 exact stent. So on lateral view it's okay, on AP there is some stenosis, but I think the radial force of the stent is okay. And now we can finish the case. Как символен да курсизаш? Ще ни дава дистент кереква, как символен? Yeah. Okay, the proximal part is just at the edge of the stenosis. I will ask 10-30 asanas. Asana. Yes, now the M1 segment is far more better. then the image show from the end of the angioplasty. Yes, it's a radial force of the stent also playing role. No, bitqil. Bitqil then. Yes, it's finished. Stay there. Wait, sir. This level is better. Because of the proximal part was at the edge of the stenosis. Yes, now it's better. Let's decrease the image size. Yes, MCA territory is okay. We can finish. Okay, thank you. M1 is better because of the radial force of the stent. Thank you. It was quite challenging to work under local anesthesia with the moving patients, but the first patient is okay, and now. Аяқтарыңыз қимылдатыңыз шаға. Аяқтың басын қимылдатыңызшы, аяқтың басын. Табаныңыз қимылдатыңыз, табаныңызды. Аяқ қозғаңыз. Okay. Patient is moving, he is speaking, and now we can finish the case. See you in Dubai, see you online on Sunday. Bye bye. Thank you for watching. So.